My intention today is not really to make you an expert on chemotherapy drugs, but I'll bet a lot of you have heard of these drugs.
So when we're thinking about a treatment, it has to pass the "is it worth it" question. We can make somebody very sick because we can't be specific about treating only the cancer cells and sparing the normal cells. But we can make them sick if we know we're going to cure their cancer and they're going to get up after that and live a normal life. But we can't make somebody sick if it's not going to help. And we can't blindly make somebody sick without trying to make them feel better and still have the advantages of the anti-cancer treatment.
But really the mainstay of pancreas cancer chemotherapy, traditional chemotherapy, has been a drug that many people think is very appropriately named 5-FU, 5-fluorouracil. Gemzar is a drug that came out probably about 10 or 15 years ago. A lot of the studies, because it takes so long to analyze and understand them, were looked at with gemcitabine alone or gemcitabine combinations with platinum drugs. Yes, platinum the metal. The taxanes is a very nice story. The classic drug based off of a YEU tree is Taxol. It doesn't really work very well in pancreas cancer, but its friends and cousins Taxotere, docetaxel, and something called nab-paclitaxel, pioneered here in LA. Then there's irinotecan, and then there's erlotinib or Tarceva, a drug that works by a pathway called the epidermal growth factor or EGFR pathway. And we have a lot of drugs that we can use alone and in combination, and the question is which and when and how and all of that. And
well, in 9 or 10 years we have probably 10 different drugs that work and new combinations and research that's helping us to identify who should get which drug and when they should get it and how long they should get it for. So we're on this trajectory of revolutionizing the way that we're treating cancers.
And what's nice about that is if you have somebody that has a tumor that is almost but not quite resectable, you want to pick the regimen that has the highest chance of shrinking the disease so you can convert that person to surgical resectability. With that, we'll work on curing the cancer, making the cancer more livable, and finding the what-ifs tomorrow. Thanks.